Hey guys, welcome back to Ajax Science into Practice. Jess, today we are tackling one of infection prevention's greatest illusions.
I love where this is going already.
Yeah, it's the idea that everyone has excellent hand hygiene.
Oh, is this like when people say they floss every day?
Yeah, kinda, yeah. And the results got pretty spicy. So the study that we're talking about looked at something that we don't always want to look at too closely. It's what people think they're doing versus what they're actually doing.
And let me guess, these two things aren't aligned.
Oh, no, not even a little. No. Nurses reported about 95% compliance.
Okay, so confidence there.
Yeah. With only 46% actual observed.
Oh, no.
Yeah. Now, physicians did do a little better. So about 83% observed, but still reported over 90%.
So basically, everyone thinks they're a hand hygiene hero.
Yes, yeah. And we did bring in two incredible guests today to help us unpack this whole thing with their article, Comparing Observed with Self-Reported Hand Hygiene Adherence Among Bedside Nurses and Physicians at two hospitals in the United States. First, we have Dr. Prathit Kulkarni, Assistant Chief of Medicine at the Michael E. DeBakey VA, infectious diseases physician, educator, former CDC Epidemic Intelligence Service officer. Definitely someone who has seen a lot of real-world infection prevention challenges.
Also casually directing a post-acute COVID clinic, training fellows, publishing extensively. No biggie, though.
Just a light resume. Yeah. And we're also joined by Dr. Barbara Trautner, co-chief of infectious diseases at Washington University in St. Louis, with deep expertise in UTIs and antimicrobial stewardship, and a champion for using antibiotics only when truly needed.
Also fantastic. But let's get down to it, because this gets into something deeper than just wash your hands. So this study looks at something deceptively simple, hand hygiene adherence. We talk about that all the time. It's not hard. But instead of just measuring compliance, it compares observed behavior with self-reported performance, which is where things got a little uncomfortable.
Yeah, this is always an interesting subject. I love talking about this because what they found is what we often find. It's a pretty striking disconnect. And I know I said before, but it's worth repeating. Nurses reported about 95% adherence, but they were observed at 46%. Physicians reported around 90%, but were observed closer to 83%.
And that's not a small gap.
No, it isn't. And so I'm going to lob this to our guests. Why do we think there's such a big difference between what clinicians believe they're doing and what's actually happening?
Well, maybe I'll start. First, let me just say thanks, Nicki and Jess, for having us on. It's super exciting. And also thanks to the American Journal of Infection Control for being interested in this work. So to start, to address why there might be this kind of disconnect, I might point to three different ideas, all three of which we referred to in our manuscript. The first one is the concept of sort of psychological biases. So, for example, a couple that we mention in the paper is so-called social desirability bias. That refers to the concept that when somebody is answering a survey, they tend to answer in the way that perhaps they think the person asking wants to hear. It's kind of similar to when somebody goes to the doctor and the doctor says, well, are you eating healthy? Are you exercising? And you sort of have that feeling of wanting to say yes so as not to disappoint them. Another sort of psychological bias is something called overestimation bias. It's a form of overconfidence bias, and it sort of refers to the tendency of people to think they're doing maybe a little bit better than they are. And that's not specific to this necessarily. That's kind of a broad concept. And the other sort of couple of areas which we highlight that might explain some of this disconnect is, one is that the complexity of typical patients admitted to the hospitals now is very high and is rising. And so it's possible that clinicians have to make multiple trips into and out of patients' rooms. And they may also think, well, I'm going in, I may not necessarily be about to touch the patient. Maybe this is not as important. So that could maybe play into it.
And I hear that all the time. I'm not going to touch the patient. I'm not going to touch him. I don't need to put my gown on. I'm not touching him.
Right, right. And then the final concept is sort of limited to that, which is basically time pressures. All of us face significant time pressures as practicing clinicians in this day and age. And if you're thinking about really doing it with 100% fidelity every single time, that could be a significant amount of time. And if you're in a rush, or even unconsciously, if you have to get something done quickly, it may not be on somebody's mind to focus on that. So we can talk more about these, but those are maybe some of the concepts that we touched upon in the paper.
And I'm curious, is it something that you think that they consciously are not doing, or do you think they're forgetting to do it, or consciously not doing it? Like, I don't have time. I need to save 30 seconds. I can't do that.
Yeah, difficult to know for sure. I mean, you'd really have to maybe probe on an individual level with interviews or things like that. It's perhaps some combination. My sense is probably it's more unconscious, but hard to know for sure, and perhaps both are contributing.
So this isn't just a data issue, it's a behavior issue. The study talks about things like social desirability bias, a really interesting term actually that I was thinking about as we were going through this, which is basically saying that we tell surveys what they want to hear. And I think we've all maybe done this in the past, maybe. How much of this do you think is driven by things like overconfidence or social desirability bias or actual workflow constraints?
Well, like most things in medicine, it's complicated and it's going to involve all of the above. I think one thing that may have been going on in our findings is it's possible that people have a misunderstanding about what they think is appropriate hand hygiene and what we were measuring as appropriate hand hygiene.
Fair point.
First of all, we need a big shout out to our secret shoppers. It was Michelle and Laura, and they casually would wander around the wards and watch people going in and out of rooms and watch their hand hygiene and time them. And they managed to do this without people figuring out what they were doing over more than a year.
That's a feat in itself.
Yeah. And they did all shifts. I mean, we had a lot where we were coming in at night. We had a lot where we were coming in really early in the morning. So what they saw is very accurate. They were very precise about what they saw, but what they saw was going in and out of the room. So it is possible that nurses who touch and manipulate things in the room more often were actually using the sink inside the room or possibly washing their hands before they came out of the room. We didn't see that, and sometimes there's alcohol wipe, hand solution inside the room. So if so, that we could have had a measurement bias, but I think it really might just be a misunderstanding in people's minds that if they go in the room and they touch anything even quickly, they should actually wash their hands, versus in their minds, they're like, well, I didn't touch the patient, or I didn't spend much time touching the patient, so I don't need to wash my hands. So it's possible that there's a disconnect with that.
Can I ask one quick question? I don't mean to interrupt, but did this study include all 5 moments inside of a patient's room, or are we just doing in and out?
We could only measure in and out.
Gotcha. Okay.
It would have been really hard to do it unobserved while standing inside the patient's room.
I think you said it was Laura and Michelle. They would have earned a much, much, much bigger Starbucks gift card above and beyond what they probably already earned.
Yeah, I mean, they would have had to probably hide under the bed, and I can see IV concerns with that. I mean, we like science, but there are some limits.
Yes, you're right.
Okay, so I think some of it may have been a misunderstanding between people thinking that, well, I went in and I only touched like the bed or the pillow and I don't need to do anything. So, and then they're reporting that. And then I also talked about the limitations of our observation. But I think, yes, there's a lot of overconfidence. I mean, if you survey, yes, all physicians and nurses have a lot of self-doubt, but at the same time, I think we're raised up to be fairly confident in our decisions. And so, all of us think that, for example, our patients are slightly sicker than everyone else's patients. And we all think that, on a personal level, we all think probably our pain tolerance is better than someone else's pain tolerance, right? So we're a little overconfident. And then when you're doing a survey, you're kind of doing someone a favor. You're like, I'm doing this survey because they really want me to. So maybe you're more inclined to answer with overconfidence because you're already like, well, I'm doing these people a favor. I'm doing their survey. But finally, yes, major issues with workflow constraints. I mean, when the physicians are going in the room, they often are going to just stand there and talk to the patients, whereas the nurses are going, and they're going in like twice a day. The nurses are going in and out all day long with the patients. So it's a very different workflow and demand on their time when they're in and out of the room.
Absolutely. Yeah.
And interestingly, too, like what we one of the things we've observed in the past as we were doing observations was you'll see the teams of physicians going into a room and, I know they're not really intending to touch anything. They're intending to stand there. And then you see maybe a resident put their hands on the bed rail as they're standing there, right? Mm-hmm. So like unintentional touch points that, they really weren't planning on touching anything, but they just happened to lean or like put something down or, so.
Well, yeah, because, you have a somebody bringing in a glass of water so they can take their pills. And then, I'm not going to touch the patient. I'm just going to set it down. But then they end up pulling the bedside table over for the patient or, it all just.
Adjusting their pillow.
Yeah. Which that is one thing that stood out to me is the difference between the nurses and the physicians. Like we were just saying, there's different perceptions on what you're doing when you go into the room. And nurses did have significant lower adherence, but like we just talked about, they also had far more hand hygiene opportunities and interruptions that are built into their workflow. And that's really going to impact that outcome. So how should we be thinking about designing hand hygiene expectations or interventions differently for nurses versus physicians?
Yeah, it's a really important question, Nicki. Let me start by highlight something we talk about in the paper in the results part, which is actually very interesting, which is that in part of the survey, we sort of asked physicians and nurses how much they believe hand hygiene is important for healthcare-associated infection prevention, as well as their perception or their belief about how important patients perceive the concept to be. And here it's interesting. There's a difference between nurses and physicians, and nurses, on average, their belief is way higher that hand hygiene is important for HAI prevention. Not that physicians obviously don't think it's important, but I think nurses intrinsically, at least in this paper, place a kind of a higher emphasis on that, which is fantastic. And actually, that's something potentially we can improve on the physician side. Some other concepts to think about are, one is, I think it would be interesting to kind of make folks aware of this discrepancy. Feedback can be very useful for all types of clinicians. So that would be an interesting thing to sort of take back and say to folks, oh, here are some of the findings from this study. The other thing is just acknowledging, as we've been discussing, the sort of challenges and time pressures that people face can also go a long way. It can be quite encouraging to people to express that we understand the difficulties that they may face in their sort of practical day-to-day actions that they have to take to care for patients. And then one other thing I'll mention is that there are some studies out there about different staffing ratios and things like that. Now, all hospitals are different and all nursing units are different, patient populations are different, but that is potentially something to kind of look into with regard to time constraints and things like that. On the physician side, as I mentioned, I think it would be important to continue to emphasize the importance of hand hygiene and HAI prevention. I think people sort of know it intellectually, but whether they sort of feel it emotionally is maybe a different question. And then with regard to, we touched on it a little bit, the discrepancy between, let's say, attendings and trainees. It wasn't a huge discrepancy, but it was noted. I think we, as leaders, as attendings, as folks who are sort of teaching the next generation, can role model the importance of this and continue to emphasize it as a sort of key component of patient care, really in all healthcare settings. Now, this study was on the inpatient side, but it applies in clinic, it applies in the emergency department. So I think all of us have some kind of role to play in helping to sort of galvanize the next generation on this important concept as well.
Oh, can I comment on that? Because I know we're going to talk about hand hygiene compliance among the various physician roles, and I want to expand that to make it among the physician roles and nurses. Okay, if you look at who had the highest hand hygiene compliance, it was, attending physicians, then senior residents, then interns, then nurses. So when you think about it, it's the people who are touching the patient the least are the ones that have the highest compliance. And to me, that suggests it's something about workload that's here, because the nurses are the ones that are going in and out and touching the patients the most. The interns often visit the patients on their own, whereas the attending physicians are often visiting in a team. So I want to talk about the team effect, because this is something that our secret shoppers reported. Like they would talk about the lone physician that would go in and out, which was often the intern, but then there would be the attending was only coming with the team. So I think the team gives us an important way to get after hand hygiene, because it becomes the team culture to, rub in and rub out of the room for the physicians. And in fact, on a rounding team, when you're standing outside the room rubbing your hands afterwards, that's when you're almost always going to have a little discussion of what you learned from the patient, how that impacts your plan. So there's a reason in your workflow to stand there and keep rubbing your hands. Whereas that's not true for the intern that darts in and out trying to get to rounds, or for the nurse that's in and out of the room for the 10th time in the last 2 hours. So I think there's probably a need to do slightly different strategies to encourage hand hygiene for people that are with a group versus people that are on their own.
That's an interesting observation about kind of the team approach and who can huddle and make that a part of their it's an expected culture.
Yeah, and just to follow on that, that's another observation that we've sort of made in the past is when you have an attending with a group of residents and they're going into a patient's room, if the attending does hand hygiene, then the residents are likely to do the same. If the attending does not, then some may and some may not. So I think there's also something to be said about, they're observing what their attending's behaviors are as well, and maybe following on those behaviors.
I learned from the trainees though too. Like sometimes I see them reaching for the alcohol rub and it reminds me to reach for it. So I bet that's why attending compliance is the highest, because I think we get nudged by seeing other people on the team and thinking, okay, I do need to be a good example here.
Exactly. Yeah. And it was noted that the compliance with hand hygiene, particularly with nurses, was higher when leaving the room or after patient contact. So what do you think is the perspective there?
Actually, if it's okay, I'll take that one, and Prathit can comment too. But I think we have a bit of a self-protective thought. So when you're leaving the room and you have touched the patient, your idea is to get your hands clean and it protects you. It leads me into something though I've been thinking about for a while. It's really important that we do touch our patients. Hand hygiene is also very important to protect our patients, but I'm a little concerned that the emphasis on always being clean, and if you're not super clean, you can't touch the patient, or if you're not gowned, you can't touch the patient. I'm a little concerned that on the heels of COVID, that's coming across to our trainees is we don't need to touch the patients all that often. That is not the case. Touch is healing. We have to teach physical exams. So I have found on my teams, they get used to after a while, everyone, when we go into an isolation room, they are going to gown because we are going to touch the patient. We are going to examine the patient together. And I sense a little surprise sometimes at the beginning of a rotation that they're used to the fact that we're all going to examine the patient by the end of the rotation. All that to say, we need to make sure we do hand hygiene without losing sight of the fact that fundamentally we are taking care of patients. That is what we do, and touch is part of our care.
Yeah, I agree with everything Dr. Trautner mentioned. I'll just add, again, it's a little bit hard to know for sure without sort of directly asking people, but I think psychologically, as was mentioned, there's something about this self-protective, idea that, well, I just did something. Okay, let me go clean my hand. Whereas, although it's one of the 5 moments before touching a patient, it may not feel as intuitive to folks or feel as immediately natural. The other thing is some people, particularly let's say you're going out of one room into another room, you may just you may be washing your hands as you left one room, you're going in the other one, perhaps not a
Right.
lot of time has passed, like maybe less than 10 seconds, and so mentally you think, well, I haven't really touched anything, okay, let me just go in. So I sort of understand that practically.
Yeah, if you walk out of a room and you're doing your hand hygiene as you're rubbing your hands together and walking into another patient's room, you essentially have done your hand hygiene.
Right, right. And what's that gap of time? I mean, that's a difficult question to answer. And if, let's say you finished 5 seconds, 10 seconds have passed, you legitimately didn't touch anything. Now, some people do touch things like their phone or this or that. They don't think about it. But let's say you legitimately didn't touch anything and now you're going in again. Okay, nothing could have come in those 10 seconds, but that's difficult to parse out moment to moment. So it's easier to say universally you should just do it so you don't forget.
Yeah, yes, and I think I wanted to mention too, when you're saying people are more likely to do it after they have touched the patient, that I hate to say this, but it means that people are more interested in protecting themselves by doing the hand hygiene than they are protecting the patient. And I say that because I feel like it's more mentally on your brain, like, oh my gosh, I've just touched something. That feeling is there.
That's exactly what I was going to say. I don't know if it's unconscious self-protection or just it's easier to remember because touch is something that registers profoundly in the human brain. So you're like, oh, I did this.
Yeah, no, that's a good point. That's a good point.
Well, and speaking about the amount of time between, we've sort of touched on this earlier, but like hand hygiene does take some time. And, we've also talked about the time that is spent between the nurses and the physicians. And we know that some of our nurses are doing, there's between the in and out, it's 200 plus opportunities a shift. So looking at your study, physicians spent about 13 seconds each time they performed hand hygiene, whereas the nurses were spending about 8 seconds.
And when you multiply that across dozens of patient interactions, that adds up quickly. Mm-hmm. It's not, like we said, it's not just non-compliance, it's a misperception.
Right. So you can't fix what you don't think is broken. And I think this is where we get into the why is this still so hard question. If people believe they're already doing hand hygiene 95% of the time, then maybe the traditional education may not move the needle, but what actually does help clinicians recognize gaps in their own practice?
I could start with that one. We do a little bit of public shaming, like we appoint people to note outside of rooms that someone hasn't done hand hygiene and we tell them that, or we make them stick their hands on plates and then it shows what cultures were on their hands. And these are all great, but the best way to make things work in healthcare is to make it easy, desirable, and pleasant for the person. So I can tell you hand hygiene is dramatically better than when I was an intern and it was soap and water and your knuckles were cracked and bleeding. Those alcohol rubs actually feel pretty good and some of them smell pretty good. And the nicer it is on your hands, the more likely you are to do it. And putting it right where you can reach it. Boy, that's been a fantastic innovation. So I think maybe something we do now is lean into this team culture thing, for at least for physicians. That's their moment to chat about the patient before they go in the room and their moment to chat about the plan when they get out of the room. And if you kind of build that as like your hand hygiene and your thinking moment together, maybe that'll make a difference.
Yeah, I'll just add, I 100% agree with Dr. Trautner. I would add maybe a couple of ideas. One is I do think some feedback is useful. We sort of talked about that earlier, but some continuous feedback with your own kind of data. We sort of do that sometimes for, let's say, clinical things. And it can be helpful just to know, what am I doing pretty well? What can I be maybe doing a little bit better? The other thing is, in all this effort to do a good job with hand hygiene, we focus a lot on the sort of compliance aspect, which is important. And of course, we do need to track that. But similar to what Dr. Trautner was saying about making things easy, desirable, etc., I would also add there's a sort of psychological component that giving people feedback that what we're doing makes a difference. It actually matters. It seems like a small thing. Oh, we're just washing our hands. But you may be preventing some potentially serious complications, prolonged length of stay, et cetera, et cetera. I mean, we all know the ramifications of higher HAIs. But I think emphasizing to people, hey, what you're doing is important. It makes a difference. You're making a difference in people's lives practically. I think that's important. That kind of psychological motivation can be useful rather than only framing it as compliance, for example.
So, as an infection preventionist, what practical thing might I consider doing it within my own facility to help everyone understand how much hand hygiene matters and increase, compliance with the opportunities that they're encountering?
Well, like I said, if you make it easy or desirable, people are more likely to do it. What if we leaned into the message of you're protecting yourself with the hand hygiene? Because we do seem to be finding a component of that. This bug that the patient has is unpleasant. You don't want to take it. You don't want that to join your bacteria. There are probably some ways to do messaging around protect yourself, protect your family, protect your patients. We're all on the same team or planet or something like that.
We do that. We do that here. We talk about, it's not just your patients, it's your fellow patients, and it's not just you, it's your family, it's your community. And I wonder, that'll be interesting. I wonder what the IP's perceptions are of their own facility because, we don't do as many observations. We just receive them. So I wonder, that's just an interesting side note. Nothing that's got to do with this paper though. So if we had to boil this down, we don't just need better hand hygiene, we need better insight into our own behavior.
And a little less confidence maybe, and a little more humility in the hallway.
Yeah, exactly. Maybe it's the sixth moment of hand hygiene. Self-awareness, that's the sixth moment.
That's amazing. Who, if you're listening, we've got an update for you. It's the sixth moment.
Yep. And I want to give a shout out to Michelle and Laura too. You mentioned them earlier. That's a lot of hard work. So I hope they did receive a very, very large Starbucks gift card. And if they didn't, Michelle and Laura, if you're listening, I'm lobbying for you to get that.
Taking
you all
notes.
Can't see this, but Doctor, do you all have anything else you want to add?
Before we wrap up here, I just wanted to also, since we're doing shout outs, I want to give a shout out to our fantastic collaborators. This was obviously done at a couple of centers, and we had a great time collaborating with them. They're a great group, great team, and they had to do all the similar things at their hospital as well. So it was a real team effort, and it was fantastic to work with them as well. So I feel remiss if we didn't give them also a very important shout out.
Yes, thank you, Prathit. So collaborators at University of Michigan, and then this was funded by VA Office of Research and Development, showing that the VA funds research that is very important and practical to delivery of good health care.
Well, I want to say a big thank you. Our shout out is to our guests. Thank you all for joining us today. And I'll shout out to Jess for being my amazing co-host. And then most of all, to our listeners. Thank you all for joining us. And guys, as I like to say, that's a wrap.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.